Welcome back to the Deep Dive. Today we're doing something a little different, shifting gears into what I'm calling exam survival mode.
I like that.
Yeah, because I know so many of you listening are MD postgrads, and especially if you're staring down the barrel of the Gujarat University finals or, your national boards, you've got the stack of books, Miller on one side.
Yeah, and Artuzio on the other.
Exactly.
Yeah.
And a whole lot of coffee right in the middle.
It's a scene I remember well. And honestly, even if you're not about to sit an exam, this topic, it's the absolute bedrock of what we do.
For sure.
I mean, if you can't confidently manage hemodynamics in the OR or the ICU, you just can't be an anesthesiologist. It's that fundamental.
Okay, so let's set the scene for this deep dive. I'm going to be the exhausted, maybe slightly panicked postgraduate student.
A familiar role.
Totally. I've got all these concepts sort of floating around in my head, but I need to pull them together into something I can actually say in an exam without, sounding like a complete idiot.
And I'll be the senior faculty, the examiner who's deciding your fate.
Please be a kind one.
I'll try to be a benevolent examiner, but we have to be rigorous. The goal here is to basically build the perfect long answer and get you prepped for that table viva that you know is coming.
Right.
We're going to dissect the big vasodilator triad, nitroglycerin, Fenoldopam, and the real heavy hitter, sodium nitroprusside.
The big three. I swear they show up everywhere.
Yeah.
Long questions, short notes.
And definitely when you're standing there holding a syringe and viva, and the reason we examiners love asking about them is, well, you can't fake it. You either understand the underlying physiology or you really, really don't.
No hiding.
None at all. So let's open up the stack we're referencing. We're pulling from Miller's Anesthesia for the deep physiology, Yao and Artuzio for the clinical case-based logic, and of course the ARC book for those high-yield exam bullets.
Okay, fantastic. Let's start at the very beginning then, part A, the overview. So if I get that dreaded 20-mark question that just says, vasodilators, where do I even begin? I can't just start listing drugs, can I?
No.
Absolutely not. That's a classic mistake. Don't just jump into nitroglycerin is an organic nitrate. You have to zoom out first. Start by defining what vasodilators are, but in our context.
So in the context of perioperative blood pressure control.
Exactly. Frame it. Anesthesia is, in many ways, the art of managing the autonomic nervous system. We use these specific agents to counteract very specific, very stimulating events.
You mean like laryngoscopy, intubation, the skin incision, all that stuff?
Precisely that stuff, or something major like an aortic cross-clamp. We're managing acute hypertension to prevent damage to the brain, the heart, to the kidneys. But we also use them for the opposite, right?
For controlled hypotension?
Yes.
Yeah.
Deliberately dropping the pressure to create a bloodless field for, say, ENT surgery or neurosurgery. The examiner needs to see that you understand the purpose before you even start talking about the tool.
Okay, so the purpose is all about achieving hemodynamic stability.
Right.
But to get there, we have to talk about the plumbing, the basic vascular physiology.
And this is where you can really impress. You need to anchor your entire answer, your whole thought process, on one single formula.
Let me guess. BP equals CO times SVR.
Blood pressure equals cardiac output times systemic vascular resistance. You got it. It's Ohm's law of the circulation, really.
Right.
Now, you have to break that down. The vascular system isn't just one big pipe, is it? It's divided into two functional territories. You've got the resistance vessels.
The arterioles.
The arterioles. And then you have the capacitance vessels.
The veins.
The veins. I always like your plumbing analogy for this.
Yeah, I think of the arterioles as the little faucets at the end of the pipes. They control the overall pressure in the system. And the veins are like the big storage tanks in the basement. They determine how much volume is actually available for the pump to use.
It's a perfect analogy to keep it straight in your head. And clinically, this translates directly to afterload and preload. Arteriolar tone, the tightness of those faucets, determines your SVR, your afterload. If you clamp down on the arterioles, the heart is suddenly pushing against a brick wall. If you dilate them, you drop that afterload.
And the venous tone, that's our preload.
That's your preload. The venous system holds, what, something like 70% of your total blood volume? It's a massive reservoir.
Wow, that much.
Oh, yeah. So if you dilate the veins, venodilation, you make that reservoir even bigger. Blood starts to pool in the periphery, which means less blood returns to the heart. Your preload just drops.
And getting this distinction right is absolutely critical for the exam, isn't it? Because just saying I'm lowering the BP isn't nearly enough.
It's the difference between a pass and a distinction, truly. An examiner wants to know how you're lowering it and why you chose that method.
So, for example, a patient with a failing heart.
Perfect example. Imagine a dilated cardiomyopathy. The heart is boggy, it's overfilled, it's on the flat or maybe even the descending part of the Starling curve. What does that heart need?
It needs to be unloaded. It needs preload reduction.
Exactly. You want to take some of that volume away from it, so you'd pick a Venodilator.
Okay, but what if it's a hypertensive crisis? A young person whose heart is strong, but it's just squeezing against this massive resistance.
Then they need afterload reduction. You need an arteriolar dilator to open up those faucets.
So really, before we even touch a drug, the question we're asking is, does this patient need preload reduction, afterload reduction, or maybe even both?
Always. That is the essence of selective vasodilation. And with that foundation, we can now apply this to our first agent, the Venodilator king.
Nitroglycerin, NTG. So this is part B of our discussion. It's an organic nitrate, and it feels like the absolute bread and butter of cardiac anesthesia.
It is. It absolutely is. When you introduce NTG in an exam, your opening line should be something like, nitroglycerin is a prodrug that acts primarily as a venodilator,
Okay.
reducing preload with minimal effect on systemic vascular resistance at standard clinical doses.
Prodrug seems like a really key word there, so it doesn't actually work by itself.
No, it doesn't. And this brings us right to the mechanism of action. This is a very, very high-yield topic for the Viva. So NTG gets into the vascular smooth muscle cell, but it can't release nitric oxide or NO on its own. It needs help.
It needs an enzyme. I
Yeah.
remember reading about thioesters or something.
That's on the right track.
Yeah.
Specifically, it needs an enzyme called mitochondrial aldehyde dehydrogenase 2, ALDH2. And it needs sulfhydryl groups, thiols, to help with the reaction.
Okay.
That enzymatic reaction is what finally liberates the nitric oxide.
So NTG plus the enzyme plus these sulfhydryl groups gives us nitric oxide, and then what?
Then the NO goes and activates an enzyme called soluble granulate cyclase. And this enzyme's job is to convert GTP into cyclic GMP.
Ah, the cGMP pathway.
That's the one. And once you have high levels of cGMP, it activates something called protein kinase G. And this is the molecular aha moment.
Okay.
Protein kinase G basically tells the cell to hide its calcium. It stimulates reuptake into the sarcoplasmic reticulum, and it stops more calcium from coming in.
And less calcium means relaxation.
Less intracellular calcium means the myosin light chain can't get phosphorylated. The muscle just relaxes.
It's a beautiful pathway when you lay it out. NTG to NO to cGMP to low calcium and then relaxation.
Yeah.
But why the veins? Why is it so selective for veins over arteries?
That is the million-dollar question. The current thinking is that the specific enzymes needed for that bioactivation, the ALDH2 and the availability of those sulfhydryl groups, they're just much more abundant in venous smooth muscle than they are in the arteriolar muscle.
So the machinery is mostly in the veins.
Exactly, which is why at low to moderate doses, say under 100 mics a minute, you get this massive venous pooling, this drop in preload, but the SVR barely even budges.
Which explains why the blood pressure might not drop that dramatically. But if you have a swan, the wedge pressure, the PCWP, just falls off a cliff.
Precisely. You're reducing venous return, which in turn reduces the left ventricular end diastolic pressure, the LVEDP, and the wall tension.
And this leads us straight to the big clinical why. Why is this the go-to drug for ischemic heart disease? I know it's about supply and demand, but can we really unpack that subendocardial blood flow concept? That's a huge point.
It's critical. The heart muscle isn't uniform. The subendocardium, that inner layer, is the most vulnerable part. It's subjected to the highest wall tension during systole, and it only really gets its blood flow during diastole.
Right.
Now, if that ventricle is distended, if the LVEDP is high, that wall tension acts like a physical clamp. It literally squeezes the subendocardial vessels shut, even during diastole.
It's like you're stepping on the garden hose.
That's exactly it. So by giving NTG, we drop the preload, we reduce the size of the ventricle, we reduce that wall tension, we take our foot off the hose.
So you improve perfusion to the most vulnerable part of the heart just by reducing the back pressure.
Precisely. And on top of that, NTG also has some direct vasodilatory effect on the big epicardial coronary arteries and can help open up collateral. So it's increasing supply and drastically reducing oxygen demand by lowering that wall tension.
That is the perfect exam answer for why NTG in angina. Okay, let's touch on pharmacokinetics. It's fast, right?
Very fast. We're using it IV in the OT and ICU. Onset is 1 to 2 minutes. The half-life is barely 1 to 3 minutes. It gets chewed up really fast in the liver by nitrate reductase.
Which makes it perfect for titrating.
Exactly what we want. On, off, adjust minute by minute.
Okay, let's list the clinical uses for the exam. The big ones.
Number 1 is ischemic heart disease and angina, no question. Number 2, acute coronary syndromes. Number 3, acute heart failure, especially if there's pulmonary edema.
Because it basically bleeds the patient into their own venous system, right?
Yeah.
It just pulls fluid away from the lung.
You got it, and unloads that pulmonary circuit.
Yep.
We also use it for perioperative hypertension, especially in cardiac patients. And, for controlled hypotension, although it's often not quite potent enough on its own for a young, healthy patient.
Now for the problems. The adverse effects. I know tolerance is a huge one. Tachyphylaxis.
It is. You run an NTG infusion for 24 hours straight, and you find it just stops working as well. And why is that?
Is it because we run out of those sulfhydryl groups? The cofactors for the enzyme get depleted.
That's the leading theory, either depletion of the sulfhydryl groups or direct inactivation of the ALDH2 enzyme, which is why you have to give the patient a nitrate-free interval to let the system reset.
Makes sense. What about reflex tachycardia? We're dropping the preload, so the baroreceptors are going to sense that and fire back, right?
They often do. The stroke volume drops, the body panics, and the heart rate shoots up to try and compensate for the cardiac output. And that's really bad for an ischemic heart. Tachycardia just burns through oxygen.
So what do? We have to treat it.
You do. You don't necessarily stop the NTG if it's doing its job on the ischemia front. You add a beta blocker, a little metoprolol or a bit of esmolol to blunt that reflex rise in heart rate.
Got it. Okay, one last potential trap with NTG. Hypoxia. Why would giving a vasodilator make my PO2 go down?
Ah, yes. This is all about the inhibition of HPV. Hypoxic pulmonary vasoconstriction.
Right.
So normally your lungs are incredibly smart. If you have a collapsed lung or an area that isn't getting any oxygen, the lungs constrict the blood vessels going to that area. They shunt blood to the healthy parts.
To match ventilation with perfusion.
Yeah.
VQ matching.
Exactly. But NTG is a non-selective pulmonary vasodilator. It relaxes all the vessels, including the ones in the bad lung that we're trying to constrict. So now you're sending blood to a part of the lung that has no air in it. You're creating a shunt.
And the patient's saturation drops.
It can, yes. It's usually a pretty mild effect, but if you have a patient with ARDS or really severe lung disease, it can be quite significant.
Okay, that makes perfect sense.
Yeah.
Let's pivot. We've done the venous king. Now how about the renal specialist? Part C, Fenoldopam.
Fenoldopam. This is your ace in the hole, your secret weapon for hypertensive emergencies, especially when the kidneys are involved.
And the classification.
It's a selective dopamine 1 or D1 receptor agonist.
And I need to stress the word selective in the exam. This is not just low-dose dopamine.
Absolutely not. Renal dose dopamine is a myth we've largely and thankfully debunked. Dopamine is a dirty drug. It hits alpha, it hits beta, depending on the dose. Fenoldopam is like a laser-guided missile for just the D1 receptor.
And where are those D1 receptors found?
Primarily in the renal vasculature, also in the mesenteric beds and the coronary arteries.
So the mechanism of action. We stimulate D1. What happens inside the cell? Is it cGMP again?
No, it's a completely distinct pathway. D1 receptors are GS protein coupled. They activate adenylyl cyclase, which then increases cyclic AMP.
The CGMP.
Oh, okay, so CMEP, a different second messenger.
Different messenger, but the end result in the vessel is similar vasodilation. But the systemic effect here is primarily arteriolar. It drops SVR. It reduces afterload.
But the real magic is what happens in the kidney. The double benefit.
Exactly. You see, most vasodilators, when they drop your systemic blood pressure, they inevitably lower the perfusion pressure to the kidney. And if you drop it too much, the kidneys can take a real hit. Right. But Fenoldopam is unique. It drops the systemic BP, but at the same time, it actively dilates the renal afferent and efferent arterioles.
So your flow equals pressure divided by resistance. If you drop the pressure a bit, but you drop the resistance even more, your flow can actually go up.
That's it, exactly. It maintains or can even increase renal blood flow despite a lower systemic pressure. And crucially, it also causes natriuresis. It inhibits sodium reabsorption in the proximal tubule.
So it helps you pee out salt and water. That sounds just about perfect for a fluid-overloaded patient with renal failure.
That is the textbook indication, a hypertensive urgency or emergency in a patient with renal insufficiency.
But does it actually, save kidneys? I feel like I've heard some debate about that.
You have to be nuanced here for the exam.
Yeah.
Physiologically, yes, it absolutely improves renal blood flow and hemodynamics. Yeah. Clinically, the evidence that it prevents the need for dialysis is, well, mixed. It's controversial.
So for an exam answer, you emphasize its unique physiological benefit, its ability to preserve renal hemodynamics in a way that S&P or NTG simply can't.
Got it. And pharmacokinetics.
It's a continuous IV infusion, very rapid onset, about 5 minutes, and a short duration. The elimination half-life is around 5 to 10 minutes, no active metabolites. It's a clean, safe drug from that perspective.
And the adverse effects.
Similar to the others in some ways, you can get hypotension and reflex tachycardia, but there is a very specific one you should know for the Viva. It has to do with the eyes.
Intraocular pressure.
Yes. Fenoldopam can increase IOP. So in a patient with glaucoma or, say, an open globe injury, it would be relatively contraindicated. That's a little gem to have in your back pocket.
Noted. Glaucoma equals no fenoldopam.
All right. Are you ready? We've arrived at the main event, Part D, the drug that kind of scares everyone, but we still use it all the time. Sodium nitroprusside, SMP.
The sledgehammer.
The sledgehammer. It is the absolute gold standard for potency and speed. If you need the blood pressure down right now, this is your drug. It's a direct-acting vasodilator.
And unlike NTG, this one is balanced, right?
Perfectly balanced. It works on both arterial and veins equally. It just crushes afterload and preload simultaneously.
It's so the mechanism of action. It's also nitric oxide, isn't it?
Yeah.
But there's a difference.
A crucial difference. NTG is a prodrug that needs enzymes. SNP is an iron nitrosyl complex. It releases NO spontaneously when it comes into contact with sulfhydryl groups, like on red blood cells. It does not need any enzymatic cleavage to start working.
The pure no donor.
Exactly. It just dumps nitric oxide directly into the system. And that's why it has essentially zero onset time. You turn it on and the pressure just drops. And it works in everyone. There's no enzyme deficiency to worry about.
Pharmacokinetics? It's IV only.
Yeah.
And you have to protect it from light.
Yes. You will get roasted in an exam if you forget the light protection. The molecule itself is unstable. UV light degrades it into, well, cyanide. Yeah. If you see the bag turn a dark blue or brown, you throw it away. It's toxic.
Blue means cyanide. That's a good thing to remember.
A very good thing to remember.
In monitoring, what's the minimum?
The minimum is mandatory. Invasive arterial blood pressure monitoring. An art line. You absolutely cannot manage an SNP infusion with a cuff that cycles every 3 or 5 minutes. The patient could have a stroke in that interval. You need beat-to-beat monitoring. No exceptions.
Okay, let's talk clinical uses before we dive into the really scary toxicity stuff.
Hypertensive emergencies, malignant hypertension, hypertensive encephalopathy. It's also the classic agent for controlled hypotension in things like neurosurgery aneurysm clippings or major spine surgery where you need to minimize blood loss.
What about for an aortic dissection?
Yes, but with a huge flashing neon sign caveat. You must give a beta blocker first.
Because SMP causes a really bad reflex tachycardia?
A severe reflex tachycardia. And it also increases DPDT, the rate of rise of ventricular pressure, the velocity of ejection. If you increase the force and the rate of ejection into an already dissected aorta, you increase the shear stress. You can actually make the tear worse.
Wow.
So you block the rate first, esmolol, labetalol, then you give SNP to lower the pressure.
Then dilate. Got it. Okay. Part 17 of our outline. The big one. Toxicity, the absolutely essential topic. Let's talk about cyanide.
You have to know this pathway cold to pass.
Right.
The SMP molecule has 5 cyanide groups attached to 1 iron atom. When it breaks down to release NO, those cyanide groups are set free.
And how does the body normally handle that?
Okay, it's a multi-step process. Step 1, some of that cyanide binds to methemoglobin in the blood, which forms cyan-methemoglobin. This is sort of a temporary safe buffer.
Okay.
Step 2, the real detoxification happens in the liver. An enzyme called rhodinase takes the cyanide and combines it with a sulfur donor, usually thiosulfate, to form thiocyanate.
And
then step 3, the thiocyanate is excreted by the kidneys.
Okay, so metmate buffer, then liver rhodinase, then kidney excretion. So when does it all go wrong?
It goes wrong when your infusion rate outstrips the liver's ability to detoxify. Generally, we're talking about doses greater than 2 micrograms per kilo per minute for prolonged periods, or if the patient has liver failure, or if they run out of those sulfur donors.
And what is this cyanide actually doing at the cellular level? Why is it so toxic?
It binds to cytochrome oxidase in the mitochondria. This is the very last step of the electron transport chain. It completely shuts down oxidative phosphorylation.
So the cells can't use oxygen, even if it's there.
Exactly. It's called histotoxic hypoxia. The blood is bright red, full of oxygen, but the cell is starving to death, so it switches over to anaerobic metabolism.
And that's what leads to the clinical signs we need to watch for.
The very first sign is often tachyphylaxis. You find you have to keep turning the infusion rate up and up to get the same blood pressure. If you see that, you should be very worried.
What's next?
Next is a profound metabolic acidosis with a sky-high lactate level. And the third classic sign is venous hyperoxia. You draw blood from a central line, and it comes back looking bright red, almost like arterial blood, because the tissues aren't extracting any oxygen.
Bright red venous blood. That's the one to remember. And the treatment.
Stop the infusion immediately, give 100% oxygen, and then you have your antidotes. Number 1, sodium thiosulfate. You're just giving the liver more sulfur substrate for the rhodinase enzyme to work with.
Makes sense.
Number 2 is sodium nitrite. This actually induces methemoglobinemia. You're creating more of that buffer to trap the cyanide, but you have to be careful because you're also reducing your oxygen carrying capacity.
And the third one.
The third and increasingly preferred one is hydroxycobalamin, vitamin B12A. It binds directly to cyanide to form cyanocobalamin, which is just regular vitamin B12. It's very safe and very effective.
That's a great summary. Okay, and just briefly, thiocyanate toxicity, that's different.
It is. That's a later problem. Thiocyanate is the breakdown product, remember. So if your patient has a renal failure, they can't excrete it. It builds up.
And what does it do?
It's a neurotoxin. It causes confusion, psychosis, hyperreflexia, seizures. It's not an oxygen problem, it's a brain problem.
So the simple rule is, liver failure puts you at risk for cyanide toxicity. Renal failure puts you at risk for thiocyanate toxicity.
That's the perfect way to remember it.
Okay, one last concept with S&P. Coronary steel. I've heard it called Robin Hood in reverse.
Yes, it's a favorite Viva question. So S&P dilates all the small arterioles. Now, in a patient with coronary artery disease, the vessels that supply the ischemic part of the heart are already maximally dilated. They're trying to get as much blood there as possible. They can't open up anymore.
Okay.
But the vessels supplying the healthy parts of the heart muscle, they still have some tone. S&P comes along and dilates them.
So the resistance in the healthy area drops.
And blood, like water, follows the path of least resistance. It shunts away from the ischemic area, which has a fixed high resistance, and flows into the newly dilated healthy area. You literally steal blood from the tissue that needs it most.
And that is exactly why NTG is so much better for ischemia, because it doesn't have that potent arteriolar effect.
Precisely. Now, clinically, how significant the steal phenomenon is with SMP is still debated, but for the purpose of an exam, it is a real and dangerous thing.
Understood. Okay, wow. We have covered a massive amount of ground. Let's try and pull it all together in Part E, comparison and integration. Imagine the examiner hands me a blank piece of paper and says, draw me a comparison table. What are the essential columns?
You need 4 key columns.
Yeah.
1, mechanism. Is it enzymatic NO, a D1 agonist, or spontaneous NO?
Okay.
2, selectivity. Is it venous, arterial plus renal, or balanced? 3, onset and offset. All are rapid, but S&P is the fastest by far.
And the last one?
4, key toxicity or limitation. So for NTG, it's tolerance. For Fenoldopam, maybe the IOP issue. And for S&P, it's cyanide and coronary steel.
That's perfect. That's the money shot right there. Okay, let's do a quick rapid fire. Choose the agent. I'll give you clinical scenario.
Go for it.
Scenario 1, a 55-year-old man for a CABG. You're inducing anesthesia. His BP is 180/100, and you see ST elevation on the ECG.
Easy. Nitroglycerin. You have active ischemia. You need to reduce preload and wall tension to help that subendocardium. You avoid SNP because of the risk of coronary steel.
Perfect. Scenario 2, a 25-year-old woman for clipping of a cerebral aneurysm. The surgeon is shouting, the brain is tight, I need a mean pressure of 60 now.
Sodium nitroprusside. You need potency, you need speed, and you need immediate control. She's young, her liver is healthy, she can handle the cyanide for the duration of the case. NTG is a bad choice there because venodilation can actually increase intracranial pressure. SNP is the surgical scalpel you need.
Okay. Scenario 3, a 70-year-old diabetic with known chronic kidney disease. His BP is 220/110, and he needs emergency surgery.
Fenoldopam. Protect those kidneys. You get the afterload reduction you need, plus the unique renal blood flow benefit. SMP is risky because of thiocyanate accumulation if his kidneys are already bad.
Last one, aortic dissection.
Trick question. Esmolol first. Then, once the heart rate is controlled, you can add SNP or maybe Fenoldopam. Never, ever vasodilator monotherapy in dissection.
Fantastic. So what are the big Viva traps? Where do students commonly trip up on this topic?
Okay, number 1 is dose calculation, not knowing how to mix SNP. The standard is 50 milligrams and 250 milliliters of D5W, which gives you 200 mics per ml. If you can't quickly calculate the infusion rate in LL per hour for a patient, you will not pass.
Okay.
Number 2 is monitoring. Talking about SNP without immediately mentioning the need for an arterial line, that's an immediate patient safety fail.
And the third.
Confusing the mechanisms. Saying that NTG releases NO spontaneously. It does not. It needs the enzyme. That's a fundamental error.
And what about diagrams? If it's a written question, should I be drawing things?
Oh, absolutely. Draw the NO-cGMP pathway. It shows you understand the molecules. Draw a simple diagram of the Starling curve and show how NTG shifts it to the left by reducing preload and how SNP shifts it down and to the left. A good diagram is worth at least 5 marks.
All right, this has been amazing. Let's wrap this all up. Can you give us the final summary,
He's beat.
the elevator pitch for the candidate who's about to walk into the exam hall?
Okay, here are your absolute take-home points. 1, hemodynamics is king. Always know if you're treating preload, afterload, or both.
Right.
2, NTG is for the heart. It's a venodilator, it needs enzymes, and you have to watch for tolerance. 3, Fenoldopam is for the kidneys. It's a D1 agonist that preserves renal blood flow.
And SNP.
4, SNP is for the crisis. It's a balanced, potent dilator that releases NO spontaneously. You absolutely must watch for cyanide, which presents as acidosis and bright red venous blood. And 5, safety. Always monitor invasively with these potent agents.
That's brilliant. Okay, how about a final provocative thought to leave us with?
Well, we've just spent all this time on these 3 classic drugs. But if you look at a modern ICU or OR, you're seeing more and more of drugs like clevidopin. It's an ultra-short-acting calcium channel blocker.
Right.
It's metabolized by esterases in the blood, so it doesn't depend on the liver or kidneys, and it has absolutely 0 cyanide risk. So the question is SNP destined for the history books? As an examiner, I'll always test you on it because it teaches you so much critical physiology. But clinically, the sledgehammer might just be getting replaced by a precision laser.
Something to think about for the future. But for now, I think I'm going to go memorize the structure of cyanide hemoglobin.
Go do that. Good luck.
Thanks so much for this masterclass. And to all of you listening, good luck with your exams. Go crush it.